I'd like to thank our moderators and the college for inviting me to talk today. My name is Heidi Bana. I will be talking to you about intraoperative considerations and creating an optimal stoma under challenging circumstances. I have no disclosures. First, I think it's important to define challenging circumstances. Obesity is a huge epidemic in this country, and we are seeing this everywhere, but congratulations to our top 5 obese states, Mississippi, West Virginia, Arkansas, Oklahoma, and Kentucky. Along with obesity often comes a short, thickened mesentery. We're seeing a lot more obstructed colon pathology in patients that have delayed care, whether it's for COVID or lack of resources, and the extra challenge of the deformed abdominal wall. So what are our options? Ideally, we should try and avoid the ostomy. There's so much data regarding the safety of anastomosis in unprepped bowel. There's a plethora of data regarding not needing diversion for low non-radiated anastomoses. There's the option to delay definitive management, take a second look and perform anastomosis at a later time. Colorectal anastomoses with diverting loop ileostomy is often technically easier and may be safer than an end-left colostomy. But unfortunately, we're here to talk about the unavoidable ostomy. And you've already heard from previous colleagues in this panel about the importance of ostomy marking in multiple sites and really having a fantastic ostomy nurse and ostomy care at your hospital. But a healthy ostomy in a suboptimal location is certainly better than a dead ostomy in the ideal location. Keep this in mind. Intraoperatively, do not commit to the ostomy site until you have mobilized your bowel, you're ready to extracorporealize, you've gauged your length and your tension, and often it may not be exactly at the ideally marked ostomy site. Don't underestimate the weight of the omentum. Mobilize, mobilize, mobilize. We'll talk first a little about the lateral mobilization. Peritoneal reflection should be taken superiorly to mobilize the entire left colon, staying medial and avoiding Gerota's fascia. Entering the lesser sac after separating the omentum from the transverse colon is key. In the medial mobilization, high ligation of both the IMA and IMD can help lengthen the mesentery. You must preserve the arterial arcade along the colon and not take these end vessels. Superior dissection after you divide the IMA allows identification and division of the IMD at its root just below the pancreas. This is shown in this photo. In the dreaded obstructed colon, often we decompress the colon for easier manipulation. This can decrease the size and improve your chances at creating a smaller abdominal wall defect for your ostomy. Also, the mobility increases with less distension, and our ability to assess the viability of the bowel is enhanced. I'm not going to talk much about ICG in this presentation, but ICG can be used as an adjunct to assess viability of the bowel. Multiple techniques have been described to minimize contamination. In the pictures depicted here, they are showing the decompression of the colon using a laparoscopic trocar with the valve in order to minimize any spillage. We all have dealt with the tough end colostomy. Creating windows in the medial and lateral aspects of the mesocolon can be helpful to create more length. The mesentery adjacent to the terminal left colon can be trimmed as long as the marginal artery is left intact and attached to the colonic wall. Oversized abdominal trephine can allow passage of a thick colonic mesentery. And a stoma site above the umbilicus is often helpful in these cases. And if all else fails, you just cannot get this end to reach. There is the pseudo loop, where you're bringing up a few inches proximal to your end, somewhere where the mesentery is longer, where there's less tension, and you can bring this up and mature that stoma as depicted here. We're going to shift gears a bit and just talk about the difficult ileostomy. Again, supraumbilical placement can be helpful. Mobilization of the small bowel mesentery should be taken all the way down to the base of the duodenum. The ileocolic artery can always be ligated at its origin without subsequent stomal ischemia or other consequence. And although not ideal, you can perform an ileostomy that is not brooked or everted. A few more tips. Many of us use Alexis or self-retaining wound retractors of some sort for many abdominal procedures, but they can be used for the ostomy to place this through the stoma opening and improve the ability to slide and advance the ostomy through the abdominal wall. We can perform a subcutaneous lipectomy where the subcutaneous fat is removed, the skin can be affixed down to the fascia. And this can be helped using closed suction or JP drainage to help obliterate that dead space. And lastly, a tenuous stoma should really be matured prior to closure of the midline incision. Why? Because often if you close the difficult midline incision on a deformed abdominal wall or an obese patient, you may accept a marginally perfused stoma rather than go back and open up that midline again. This photo on the left depicts the wound protector and advancing the stoma through. And on the right, you see those windows on the mesentery to lengthen. So for that thick mesentery through the thick abdominal wall, another option is separating the skin and subcutaneous tissue from the fascia muscle layers. You can bring the ostomy through these layers separately, first through the fascia and muscle, and then feed them through that thick subcutaneous and skin layer. You always want to feed the stoma through the fascia rather than pull through the skin opening. This is a picture here on the left depicting going through first that fascial and muscle layer and then feeding through that skin and subcutaneous tissue second. Stoma rods. There is a great deal of literature about no longer really recommending routine use of stoma rods in your everyday elective lubostomies. However, in the difficult ostomy that we're discussing with the heavy mesentery or brittle bowel, stoma rods can help support the bowel. You can even use 2 rods alongside each other, distribute the tension over a greater surface, and this can be helpful in supporting your ostomy. Another way to support it is to actually support it at the level of the mesentery. So you can place a rod along the, to support the mesentery along the fascia. So this braces the mesentery. You can use a long malleable tube over a vascular tunneling device, pass this through a skin incision away from the stoma, along the anterior fascia, piercing through an avascular portion of the stoma's mesentery, and then coming up to the skin on the opposite side. And that's shown here using that long tube. And actually in this photo, it's doing that for a pseudo loop, pseudo end. So some final thoughts on the difficult stoma. Don't forget about the pseudo loop as a viable option if that endostomy just won't reach. Tension is never your friend. The ostomy site, while using the ideal as ideal, may not be possible. Mesenteric medial mobilization. Cannot stress the importance of this to really get maximal length. And the abdominal wall tricks that were mentioned here, and there are others certainly that I've missed. Keep all of these in mind with that difficult stoma. Thank you to the college and again to this panel.